Thank you everyone for coming today. As Gautam mentioned, these conversations could be triggering. If any of you feel uncomfortable, please don't sit with that discomfort. You can step out. I think Gautam mentioned that there's a mental health support desk outside, and any one of the volunteers will be able to direct you there. All right, so I am very pleased to be sitting in between two people who have been doing excellent work in the area of suicide prevention. Let me start by introducing them to you. Let me start with Dr. Cherian. I first met him, I think, in 2017, 2018, and I've been following his work since, and he's been doing excellent work. And he is the additional professor and lead for NSPRITE in NIMHANS, Suicide Prevention Research Implementation Training and Engagement Center. I'm glad that this has been established. And he's the national representative, along with Dr. Lakshmi, for the International Association for Suicide Prevention. And he's the regional coordinator for the Southeast Asian for IASP. His focus on setting up self-harm registry, intervention for self-harm, suicide attempt survivors, and he'll talk about that work later, community-based suicide prevention, and also workplace suicide prevention. And he has 8 funded projects in the area of suicide prevention. Notable among them is Suraksha, Ushas, Yashas, Empower, and Samast. Besides that, he has been conducting suicide prevention gatekeeper training and has established an excellent 3-month certificate course on suicide prevention, which I think if some of you have not attended, you all should. He also is supervising 10 PhD level candidates. So that's about Dr. Anish. And I have with me on the left, Dr. Nandini Murali. I recently got acquainted with her in her work, and I'm surprised. And I think one of the reasons is because of the silence and not enough information around suicide prevention. But I'm glad to be sitting here and moderating this panel. Dr. Nandini Murali is a gender and diversity professional and a certified life coach with a focus on loss and transition, which is very important and hardly addressed. She has 3 decades of experience in the fields of communication, gender, sexuality, mental health, and reproductive health rights, and has worked with people affected with HIV/AIDS, other vulnerable populations, sex workers, people with disabilities, and non-binary people. She's sitting here today because of her lived experience as someone who's affected by suicide, impacted by suicide loss. And she channelized that grief, disenfranchised grief, into establishing SPEAK, which is Suicide Prevention, Post-Prevention Education Awareness Knowledge, an initiative motivated to change conversations on suicide and promote mental health. She also played an integral role in the establishment of Speak to Us, a mental health helpline. And she is the author of a book which is called Left Behind. All right, so we're going to break this down into 3 sections. We first want to talk about the current situation. Next, we'll address about what's happening and the gaps. And finally, we are looking to maybe look at some of the solutions to this problem. So let's get started with the numbers. So I think a lot of us know that there are 1.72 lakh suicides in the country. But there's an invisible suffering, pain and anguish to those who attempt suicide. For every suicide, there may be 20 to 25 attempters. So first up, the 1.72 lakh numbers may be severely underreported. So the WHO Health Organization and the Global Burden Disease Study say there could be 1 lakh more. So now you start to multiply that. So if you have 1.72 into about 20, those are the number of people who attempt. And then research suggests for every suicide, there are about 135 people who are impacted by it, and up to 35 who are severely impacted by it. So what happens to them? They're surrounded, as Nandi wrote in a book, there's shame, there's secrecy, there's stigma, and they're unable to talk about it. And there is a lack of support for those who attempt suicide and those who are impacted by suicide loss. And that could lead to depression, addiction, premature death, dropping out of the workplace, and so on. So first up, I'd like to address this question to Dr. Anish. Dr. Anish, in your clinical and research experiences, what are the issues that suicide attempters and those impacted by suicide loss face?
Thank you so much, Nelson, for the introduction, and thanks for the foundation for having this conversation. It's very important, and thank you all of you for joining us, because it's a less spoken and less given importance for especially suicide research and suicide work, suicide prevention in general. The very important factor, we started our work, I think as you know, that we started something around 7 or 8 years back. And somewhere we also realize the numbers, what we see is very, very, it is an unreported one. First, we established a suicide registry in 5 general hospitals in Bangalore, which now I think last 1.5 years, we have around 8,000 plus cases of self-harm. And out of this, 500 brought death. So that the number of death is like in 5 general hospitals quite huge. It's hugely unreported. And the major issues I will break into two. One is self-harm, the people who actually attempt, and the people who lost, the families of bereaved. The self-harm, first of all, they don't able to tell people that they are distressed. We are in a world where we can't tell people that, I'm not okay. That's where the journey begins, because, and they do the self-harm. They come to hospital, they suffer from huge stigma. They shame, guilt that, okay, I'm done it. And the stigma, the social stigma and the perceived self-stigma also. The social stigma, I'll give an example. They come to a hospital and they get the last priority, because the other medical conditions will get the first priority. And the way the medical, I think we should blame ourselves, because we ourselves have huge stigma, the mental professionals, medical professionals, because I remember when we started our work in one of the hospitals here, my staff goes there and talk to a medical professional there. And Yakama Bartira, why do you want to save these people? Because they want to die. That's the way they look at this thing. And if you look at the family, either they will be over involved or so much of hostile. With both extremes. The people who are lost, the families who, the people I think Mandini will be talking about more, families of who lost their loved ones are the most ignored one, or most, they kind of, nobody will talk to them. They won't ask their pain, they won't ask their issues, and they just, stop there. And when they come back, for example, the people who attempted, after the treatment, they come back. In the hospital, what the treatment they get is just, they kind of clean up and send them, nothing else. Nothing else. I mean, across. I think I'm happy that I think we could actually set up this, and I'll talk about it a bit more later. When they come home, and nobody will talk to them. They kind of isolated, because we don't know how to talk.
Okay, I hear there's a lot of silence and shunning. On that, I'd like to, thank you for talking about this. And I think you spoke about a lot of things about the number of cases of self-harm, and, it is grossly underreported.
There is no report.
There is no report. And also, those who come into the hospital, they are the last priority.
Yeah.
And they say that suicide is the most preventable form of death. But if you were impacted at war, if you were like, if you would come into a hospital during war, they will address those who can save first.
Yeah.
So suicide, they say, is the most preventable form of death, yet they are the last priority, right? So I'd want to direct this question to Dr. Nandini, taking off from what you said about those who lose their loved one, they are shunned and not even spoken to. Dr. Nandini, please tell us as to why you are here today, and how did you get involved in the area of suicide prevention?
Thank you, Nelson, for that question. Until 7 years back, when I lost my spouse to suicide, suicide was something that would only happen to other people. in other families. I used to read about suicide in newspapers. It could not happen to me. It could not happen in my family. I had no connect with the world of suicide. But April 27th, 2017, that was the day my life changed forever. That day I realized that suicide is something that could happen to me. It could happen to anyone. So it's a very long journey, which I've written about in my book, Left Behind, Surviving Suicide Loss. But today, when I look back with a lot of wisdom, with the wisdom of hindsight, I can say that suicide bereavement, a death by suicide, is profoundly isolating. It's very, very confusing. It's very bewildering. In one instant, your world changes overnight. Nothing remains the same. You're just left with everything is washed away. My husband, Dr. Murli, was a very well-known urologist. He was an excellent renal transplant surgeon. He was a pioneering andrologist, and he was a very skilled pediatric urologist. Why am I saying this? Because, as Dr. Anish rightly mentioned, when we talk, we really are very apathetic to people who have attempted suicide. And it's that same apathy which is also carried forward to those who die by suicide. For any other kind of death, we like to remember people who have died by the way they've lived their lives. Why should it be any different for someone who has died by suicide? That is why I chose to, place my husband's life in a context. He left behind a huge professional legacy. That's how he would like to have been remembered. That's how I like to remember him, not by the way he died, which again for me is very stigmatizing. It's been extremely challenging ever since then. My life was then divided into two phases, before April 27th, 2017, and after that. Even on the day of the funeral, I just found that this was a very different kind of death. I knew nothing about it, but there have been other bereavement in the family, non-suicidal deaths in the family. I sensed that the behavior of people was very, very different. They were very empathetic. There was great support, because when we are impacted by grief, we need to grieve individually. We also need that collective around us to grieve. We need a tribe around us to grieve. That is not there in a suicide death. People would come, they were more interested in gossip, they were more interested in speculation. Why did it happen? I would be endlessly interrogated, on one hand by the law enforcing agency, because a death by suicide is regarded as a crime. And on the other hand, people would speculate, people would gossip, and it was as if I was just not there at all. And in some cases, when many of us also discover that a loved one has ended their life, it's hugely traumatic. So on one hand, you are to deal with the trauma of this death, and then of course the insensitivity of people around you. Even when I discovered the death, I was instantly overcome by a deep sense of shame. I felt very ashamed. I just said, what would I tell others? What would I tell my family? What would I tell my friends? It was then I realized that this was stigma in operation. I have a very cognitive understanding of stigma because of my work with marginalized communities. But when it came to me, it just didn't feel authentic to just keep quiet. I said, I'm going to speak up and tell the truth as it is. So that's why I'm here today. I decided to out myself because I realized that this was a huge issue, a global public health issue that needed to be addressed. And sadly, in India, people like me, people with a lived experience of suicide loss, we are not there in the suicide discourse. it's the focus in the country has largely been on prevention and intervention. There's been a complete absence of public and professional discourse on postvention. How do you help people impacted by suicide loss to rebuild their lives? So that was a light bulb moment for me. I decided I wanted to be the change I wish to see. At this point, I'll just use a very small metaphor. I'm sure we've all heard of this bumblebee. We've seen the bumblebee. Scientists say that this silly little bee, it's so tiny, it's got such oversized wings. Aerodynamically, it's not capable of flying. But the bumblebee spreads its wings about 500 times. It derives energy from the sun, and then it decides that I will prove everyone wrong. I will fly. So for me, that was my bumblebee moment. I decided I wanted to be the change I wished to see. There was no point playing the victim. So that was a huge moment of departure for me.
Thank you, Dr. Nandini. You wanted to be the change that you wanted to see and be the bumblebee. And for a lot of people, like you mentioned, I could sense the intense pain and the anguish that you felt. And like you mentioned, it was, April 2017, your life changed forever. And for some survivors, for those who are impacted by suicide loss, they remain in that survival mode, where I've heard of stories where, suppose it was at 11:17 p.m. on a certain year, it's just like that, clock on the hand, it just is stuck there, and they never move. They stay there. And I'm really happy to see that, you were talking about not just surviving, but thriving, and you being here today to tell your story to others who might be impacted by this is what is needed. So thank you. I'm glad that we are, can hear your story. And so how did it feel for you when, the attitude itself for, I sense that thing about the shame you had, or maybe that you were supposed to save this person, and what you actually got was not concern but curiosity and almost a sense of blame. And the first thought, instead of experiencing your loss and grieving, your first thought was, how should I be explaining this to someone? Yeah. How did that make you feel? It just sounds like a lot.
Oh, it was terribly overwhelming. In the initial days, I recall, I would be championing my husband. I would say, oh, he was so good at his work. He was so, he was this, he was that. And I felt a huge sense of hyper-responsibility for not having prevented this death. I said, I could have done something. I was traveling on work when this happened. And I said, oh my gosh, I should have done something. Was there anything I could have done? So I would hold myself very hyper-responsible for not having failed to prevent this loss. And then the next 1 year, I read up everything on suicidology, every textbook, every research article, every book on the subject, because for me, I had to make meaning of this loss. And what I discovered was suicide loss impacts women and men very, very, very differently. There's a huge gender dimension to suicide loss. Women, and I've also been talking to several people impacted by suicide loss over the years. Women impacted by suicide loss, whether they lose a spouse or whether they lose a child, they are kind of held responsible, because women in modern societies are seen as custodians of tradition and culture. So when a wife fails to prevent the husband's suicide, or when a parent fails to prevent the child's suicide, it's seen as a dereliction of your duty and sense of responsibility. So for me, then I realized that suicide grief is very disenfranchised. It simply means that you have no right to grieve. Society takes over your right to grieve. It denies you the right to grieve. And that for me was very, very isolating. There was complete empathy deficit. And the other thing about suicide loss is, and this is especially true for women who've lost spouses to suicide, family dynamics are disrupted, often permanently.
Right.
Yeah,
right.
and therefore for me this was Um, and I also realized that before I decided to be the change I wanted to be in the world, I had to heal myself. That's been a very interior, it's been a 7-year journey. It was one step forward and several steps backward. I accessed support groups for
Right.
for people impacted by suicide loss. These were online support groups. I didn't find any in the country. And I also heard the word postvention for the first time. And there was another incident which really marked a huge departure in my healing trajectory. There was this book, I think it just popped up in the net. I think when you really want something, the whole universe conspires to help you find it. This was No Time to Say Goodbye by Carla Fine. Carla Fine is an American journalist who also lost her spouse to suicide. When I read the book, I just felt if there was one person who understood my journey, it was she. And her husband, incidentally, was also a well-known urologist. So there were several points of similarities. And when I read her story, you know, how she had moved from merely surviving to thriving and flourishing, it really gave me a lot of hope and inspiration. I wanted to know if there were other books written by people in the Indian context. I didn't find any. And that was the moment when Left Behind was born.
Thank you. Thank you for that. So Left Behind is available on Amazon and elsewhere. Please do look it up if you feel like it could be helpful in your journey. I think you touched upon quite a few topics about, you know, trauma, loss, and the inability to grieve, the shame, the stigma, the silence, and also how grief is different for genders. So I want to now talk about what is currently being done in terms of the interventions and also explore some gaps. So quickly, Dr. Anish, who's been doing some great work, has got his project funded and now is extending the project with you know, more than 5 general hospitals. So like, I think Dr. Nandini is talking about the lack of this support. From NIMHANS side, Dr. Anish has launched a project with the government of Karnataka. Yeah, could you please tell us about the project and how's the project progressing and how are you planning to scale it up?
Yeah. This was, I think, the project which you are talking about is the USHA's Urban Self-Harm Study, which we launched. I think we are behind the government for a couple of years to get the funding for the 20 lakhs. We thought when I realized there's no self-harm registry in this country, because what we have is data from NCRB.
Could you tell me why is that important to have a self-harm registry,
yeah.
and what is a self-harm registry?
Yeah. So the what we have now is like from the NCRB, National Crime Report Bureau. Every we get the data now. The November we will get the data of 2022. It's 2 years later, and there is no point except we get the data number like what you said, 1,74,000, and when we thought like when you're working in suicide prevention, the primary aim is to reduce re-attempts, like the future attempts, because if you look at completed suicide, they would actually done at least multiple previous attempts. So it's so important for us to prevent the future attempts or the further attempts. So in that ground, we thought we will start a small work in 5 hospitals. Thinking as a researcher, we thought like we'll have a sample size calculation done, and we went to hospital. The sample size was for us to have is only 300 in 1 year. We go to a hospital nearby, it's a Victoria General Hospital. We get around 14 self-harm cases in a day. And in 1.5 years, we have got around 8,500 odd cases. And the government now we are extending it to 13.
What kind of help, just take us through what happens when somebody self-harms and comes into the hospital. What kind of help do they actually receive medically, and is there any other counseling or follow-up? Because we do know that you want to reduce reattempts, and in the first year, they are at the highest risk of suicide. So
yeah, most of the time, and most of the hospitals, when the person who comes to hospital, it's for the medical need, like primarily otherwise they won't come to hospital at all. Generally, they won't come to hospital. Around 1/3 will come to hospital. That's the number what we are talking about, this 8,500. So they come here, and most of the time, they won't get a psychiatric referral at all. Right. So they come in the night, they take the medical treatment, and they just vanish. We don't know where they go.
There's only crisis intervention.
Crisis
there's no
intervention,
follow-up. There's no
follow-ups, yeah.
diagnosis, and then find out what exactly went wrong.
Yeah. So our aim was to set up this registry first. Then we thought we will have a follow-ups also. Like we have what we do is like we kind of very basic intervention. You might know the emergency departments. It's nothing less than a market. It's a very crowded place where you can't intervene. Your confidentiality, everything will be like you can't do much work there. But what we also realized, people who actually attempt, it's not they want to end their life. They want to end their pain. They need someone to talk to. So they're ready to talk to them in any circumstance, any place, like even in the crowded place, or most of the time our field staffs will go and they don't even have a seat to sit, and just they just talk, stand and talk to them, and they build the rapport, and they talk to them, and they say the safety planning and some of the protocols we have. And after that, we thought we will call them frequently because we need to talk to them. And the first 6 months is very crucial after the first attempt. So the first month is very, very crucial. So we call them every week after discharge, second, fourth, like multiple occasions in the 6 months. And our protocol was 6 months. And after a few months, 7th, 8th month, they started calling us. Why are you not calling us? Like, I think you used to call us, and what happened? And then I thought, like, hey, we increased the duration, like in 9 months, 12 months. Now it's 24 months. And the happy thing in this entire process is we could actually reduce the reattempt to 0.9%, less than 1%. Globally, if you look at, it's about 15 to 27%. That's the reattempt rate.
Absolutely, yeah. This is amazing because yes, so somebody who attempts suicide, there's up to a 30% chance they will reattempt.
Yeah.
And about 10% go on to die by suicide. So this is statistically very relevant, and I hope this is being scaled up.
Yeah, and we lost 3 people in this entire group. That was also like they had a psychiatric diagnosis. They actually had schizophrenia and altogether different this thing. So, and our intervention is very simple, and maybe I think anybody can try, and all the hospitals, whoever in the mental health professionals or even any professionals can do it. We just talk to them. It's a kind of, we call it as a social intervention. Just talk to them. Make them comfortable, be with them.
Yeah, you mentioned that they do not want to end their life, they want to end their pain.
And
what they want to be, if they're feeling helpless, hopeless and worthless, what they want to be, what they want is to be seen, heard and validated. A simple intervention. I didn't even hear, a lot of other things involved. So something as simple as that has reduced to 0.95% of reattempts. Thank you for that, and I hope that you can publish this research if it's not published, as well as get funding for this, so this can be expanded.
It's expanded to 18 more hospitals now. I think 13 more added.
Yeah. So I just want to bring this back to you to talk about your project Speak, as well as talk us through your book and the impact that's had for you in terms of your postvention journey. Postvention, as Dr. Nandini mentioned, is reducing the pain and increasing healing through a process which eventually could lead to from surviving to thriving. So yes, please tell us about Project Speak.
Yeah. It all began, I think my involvement in suicide prevention has been very organic. Of course, it's my lived experience. And then I wanted to make sense of what was happening. So that led to a year after the tragedy, on the exact date, 1 year later, I set up Speak. Speak is an initiative to create safe, inclusive, supportive spaces for informed conversations on suicide. Because there's lack of informed conversations about suicide. And then 2 years later, when the COVID struck, we set up the helpline that Speak to Us. And then all along, I just felt that there needs to be a postvention which needs to be addressed in the country, because the focus of mental health professionals has always been on prevention and intervention. When I wanted postvention services, I couldn't access any in the country. I was a member of 2 online support groups for people bereaved by suicide loss, and that played a huge role in my healing. So just wanted to see that, if we could implement something in the country. And for me, what again worked was, Speak is not, I would like to think that I didn't set it up, but for various reasons, I've been instrumental in enabling that emerge. Speak is part of the initiatives of a very well-known mental health NGO in Madurai, where I used to live for 30 odd years. This is the MS Chelamuthu Trust and Research Foundation. It's led by Dr. C. Ramasubramanian, a very well-known psychiatrist. And then I was all along, who's been a huge, huge pillar of strength and support, who's made this, who's enabled the bumblebee to take flight, he and his family, as have been some absolutely wonderful people who've really, really been the wind beneath my wings. At this point, I'd also like to mention my parents, my absolutely loving parents, my brother, my sister-in-law, and my nephew, and some fabulous friends who are family to me. I say this because when people impacted by suicide loss are to heal, they need to thrive and flourish, you need that supportive ecosystem. It's a team sport, friends. We just can't do it alone. So, and then therefore, that was something very, very interesting, how Project Speak emerged. I was looking for, we were exploring suitable ways in which this could emerge, and there comes in the Mariwala Health Initiative. They had invited me for a consultation on suicide prevention, and where I think the need for postvention emerged. So they wanted a gender lens, and they wanted it to be led by a person with a lived experience of suicide loss. My PhD is in gender studies. It was one of those very uncanny occurrences where the personal and the professional just converged. So we work with women impacted by suicide loss. In 3 blocks in Madurai district. We have monthly bereavement support groups for these women. I used to think, oh my gosh, postvention is such a Western concept. Would it work in a country like India? I was very, very surprised, because I think suicide is the ultimate leveler. Across the world, people impacted by suicide loss go through very, very similar experiences. This is not to homogenize suicide loss, because every suicide loss is very different. But these bereavement support groups, in fact, I'm leaving for Madurai immediately after this session, because we have a support group meeting tomorrow. And for me, these are very, very safe, supportive spaces where people can talk about such a disenfranchised loss without fear of judgment. It's an absolutely zero judgment zone. People listen to other people's experiences. And the feeling is, oh, I'm not alone. Other people have also gone through this. And that is extremely, extremely validating. And several of these women have gone on to rebuild their lives with a lot of courage, with a lot of dignity. And I think support groups are an antidote to what I call the 4S: stigma, shame, secrecy, and silence. And then, of course, writing my book was a deeply healing process for me. It helped me transform. It helped me transcend the trauma. I really, really think that the death by suicide, my spouse's death, does not define me, does not limit me in any way. It's been a catalyst for some very, very important initiatives to emerge in that space. So I've healed, I'm complete. I put it out because I think how do you change the narrative? Unless you challenge the narrative, unless you stand up, unless you decide, I want to reclaim my power, because our narratives are taken over by others. And when we let that happen, we become very powerless. We become victims. And the victim mindset, the victim narratives has never appealed to me. I think it's also been part of my own inner journey. So writing Left Behind was a very disruptive act. I did it because I just felt someone has got to really talk about these issues. That said, just because I've written Left Behind doesn't mean that things are going to change. But it's a small step in what I think is the right direction. And whenever I listen to statistics about suicide, and I'm sure this is true for every one of us who's lost a loved one to suicide, suicide statistics are not mere numbers to us. They represent a loved one we have lost. They represent a life which we have lost and we can never, never get back. But through our pain, if transformation can happen, through our pain, if hope emerges, through our pain, if we can let people know that monumental sorrows can be left behind one story at a time, I think it's been worth it.
Thank you for that. I heard the word transformation, transcending trauma, healing, and that your spouse's death, it does not define you. I just want to quickly get comments from you before I just ask questions on what do you think are possible solutions beyond what currently exists. Let me start with you, Dr. Nandini. I think I heard the word that peer support can be healing because you feel seen. And what you spoke about, you feel isolated in grief, does not happen when you're seen by someone else who's gone through the same thing. I hear that all the time, and you wanted to talk about allyship over here. Could you please talk a little bit more about what you...
Thanks, Nelson. I have a wish list, so I'm going to put it out here. For mental health professionals, I would say that prevention is important, intervention is absolutely important, but equally important is postvention. And I think mental health professionals, given the kind of influence, the kind of impact they have, I think it's time that postvention is integrated into the spectrum of services offered. That is one. And the second my second wish is mental health professionals need to be trained in postvention, need to be trained in not to pathologize suicide grief, but really have the sensitivity, the nuanced insights into how do you enable people impacted by suicide loss to rebuild and move on with their lives. Move forward with their lives. The third thing I would like is to involve people with lived experiences, either of suicide loss or people with a lived experience of a suicide attempt as critical stakeholders in this process, because preventing suicide is everybody's responsibility. And I think we need to be seen as critical stakeholders. Right now, we are still on the margins. We need to be moved inside because, friends, the view from the ground is very, very different from the view 30,000 feet above. And we can give you a worm's eye view of what it is like. So our experiences, our expertise, needs to be validated and valued because we are very important stakeholders in this whole process.
Thank you.
Nothing about us without us. And then, of course, setting up support groups, suicide bereavement support groups, not mixing it up with other kinds of bereavement because this is a very, very distinct bereavement. Yeah.
Thank you. I wish we had more time, but I heard that, when we say that suicide is a public health crisis, I also heard you say that prevention is also everyone's responsibility. So, Dr. Anish, could you please tell us about what you think are some of the things that could be done in terms of, making sure there's far larger representation, as well as support and help for those who attempt, as well as those who get left behind?
So a couple of things we are actually piloting and we are kind of working with the government. One is training. I agree with Nandini about the training, not just mental health professionals, across. Suicide literacy is one thing which I think none of us have. It's not in our, I think none of us studied when we are doing our masters or even our, higher educations, no. So that's one we are actually now trying to develop, and we are piloting it with the colleges, schools, different stakeholders. That is one. Second, I think we are also continue to work with the self-harm registry and interventions, those who reach hospital. And we are also now currently working with police department to get us the data on a daily basis, real-time data, so that community-based post-prevention, we are actually, on a daily basis, like, support groups. We are trying to pilot in Ramnagar and Ballari, so that we will have not the data after 2 years, and which is, so we kind of, community-based interventions. And we, that's I think, that's our, we are kind of started working with the government. That's, I think, the immediate things which we'll do. And other things are like, as Nandini also said, I think it's not just health departments or one department's business, it's everybody's business. So I think involve as many as people possible in suicide prevention work in all across. So that's very important thing, because now it's as it like, it's a health department's work, but it's not. They get all the departments involved. It's not necessarily the suicide attempts or suicide are related to mental health issue alone. It's a larger issue. Like it's a very complex. So I think it's not mental health or health issue alone. It's broadly, I think all the departments across should be involved. And I think health professionals, we can take the lead in doing that. But it's and involve lived experience people in all every level. I think I agree with Nandini. I think lived experience people are not in anywhere, like anywhere in the picture, except when we have research protocols, we might have them as a to review, or in some funding agencies now ask for lived experience people for, and we have. Otherwise, I think we don't co-design with the people with the lived experience in developing any of the research or any of the training modules, or and those are the things which I think it's essential.
Thank you for that. So co-designing, co-creating,
Yeah.
and including, increasing suicide literacy. I think we've come to the end of this, but do we have time for audience questions?
Thank you so much for the amazing session. So this question could be benefit for all the people here. So what is the suggestion that you would give for mental health entrepreneurs, be it a product or be it a service? Maybe 3 pointers which we need to be mindful of.
Okay, so I've done some entrepreneurship, so I'll quickly say that. Please include a medical professional when you're designing any product. And there are already set protocols. For example, if you're going to design a suicide prevention app, there are WHO guidelines for designing a suicide prevention app. So you need to just go and make sure that it's evidence-based, it's medically vetted, and you also get voices of those who have lived experience.
After you get the fund, like, generally they come to us when the fund is, they get the fund. Yeah, I think it's good. Yeah.
Dr. Cherian, thank you so much for expert insights. And Nelson, thank you so much for expertly navigating this.
Thank you, everyone. Thank you.